Hello, I'm Dr. Sherman Silber, and I'm very proud to say that I'm an adjunct professor at Sun Medical School and work closely with the IVF program and the andrologists there. And they've asked me to talk about fertility preservation in pediatric male patients. Most importantly, prepubertal boys treating for cancer that will lose their fertility. How do we preserve it? And it's still not advanced. Oh, it advanced slowly. Okay, I hope this works. So let me go backwards again. I'll start one more time because it didn't work. Can I start one more time, Luke?
Okay, sure.
Okay, hi, I'm Dr. Sherman Silber, and I'm happy to say that I am an adjunct professor at Sun Medical School and work closely with the fertility program there with the andrologists who have asked me to talk about preserving fertility in prepubertal boys with cancer who are going to undergo sterilizing cancer treatment, which would absolutely make them sterile in the future. How do we preserve their fertility? There's been a lot of discussion about preserving fertility of female cancer patients that are prepubertal, but the male patients really have been more difficult. So let me go into that. So it's all about spermatogenic stem cells and human testis transplantation, and I'll go into it in detail. Now, first, a little bit of basic science. Spermatogenic stem cells stay in the basement membrane of the seminiferous tubule and renew themselves very slowly. That's very important to know. Slow self-renewal is important for all stem cells to limit the number of mutations over time. They make progenitor spermatogonia, which multiply at the fastest rate, but cannot self-renew. So progenitor spermatogonia eventually are committed to make differentiated spermatozoa, but they keep on multiplying at a fast rate. But the actual spermatogenic stem cells go at a very slow rate, which makes them actually more resistant to damage from chemotherapy or radiation. So here's a normal prepubertal boy's testes with a MAD stain, and you can see he's got spermatogonia, but without gonadotropins, there's no development beyond that. Now, the spermatogonia themselves divide at different rates. The dark type A spermatogonia proliferate slowest, and therefore, some of them, not all, but some of them are actually spermatogenic stem cells, SSCs. The pale type A spermatogonia and type B are progenitors, which divide at the fastest rate, but cannot self-renew. So all pale type A spermatogonia are committed, despite initial self-replication, to making differentiated spermatozoa. And again, this is very important because among those spermatogonia that you saw in the MAD stain, there are some dark type A, and they contain spermatogenic stem cells, which are more resistant, slower proliferating, very slow, but more resistant to chemotherapeutic or radiation damage. So this is just a diagram of the various stages of spermatogenesis. And you can see at the very beginning are the dark type A. And they're the ones that are actually, the ones that are spermatogenic stem cells are actually in the basement membrane. It's not until you get to some of the later dark A or the pale type A spermatogonia that you see them not in the basement membrane. Now, there are 6 stages of spermatogenesis, each lasting 6 days. And the developing sperm precursors have to pass through 4.5 cell layers to become spermatids. Therefore, the complete length of time to make a mature sperm is more than 72 days. So why does it take 4 months to several years for a sperm to return after chemotherapy or treating commons with gonadotropin? Well, we understand that if we look at normal spermatogenesis, and here you can see on the periphery of the seminiferous tubule, you can see the spermatogonia, and there are dark type A and there are pale type A spermatogonia. And the dark spermatogonia consist of a tiny number that are actually spermatogonial stem cells that are responsible for maintaining spermatogenesis throughout the man's entire lifetime. Women do not have these stem cells, men do. That's very important for evolutionary reasons, which I'll explain later. So in the human, compared to most animals, you'll see on the bottom that there are 6 stages of spermatogenesis based on analysis of spermatids, and they are all mosaic and chaotic in their organization around the seminiferous tubule. But for mice and rats that we study more extensively, There's 14 stages, and they go in a beautiful organized array along the tubule. That's important because when we test on a human, we know that the different stages of spermatogenesis are all mixed up, and so we're more likely to find the sperm anywhere. But if we do tests on the mouse, we might just get into an area where all there are earlier stages, and we won't get spermatids. So this is a typical seminiferous tubule of a man with normal spermatogenesis that has stage 5, stage 4, and stage 3 development of spermatogenesis. And it's only in stage 5 that you begin to see the oval spermatids. Now, don't be confused with the fact that you don't see tails, because in histology, you usually don't see the sperm tails because they're so much thinner compared to the sperm head. So this is stage 2, which really has a lot of good quality spermatids you can see on the right about to be released. And for the closer to the basement membrane, you can see the pachytene spermatocytes that really show the homologous chromosomes being lined up, being prepared for the second stage of meiosis. So slowly dividing spermatogenic stem cells make rapidly dividing progenitor cells. But the SSCs also make more SSCs. The slow rate of SSC proliferation helps to minimize the occurrence of lasting mutations. So that's the way nature really produced them. That's why they produce them. Mutations that occur in rapidly dividing spermatogonia are not cumulative. Only mutations in slowly dividing SSCs are cumulative. And that's why SSCs need to divide slowly. Nonetheless, there is still enough continual mitotic divisions of SSCs to create a mutation load of about 2 mutations per year, which is really, really rare, but it doesn't happen that way with oocytes. Oocytes don't undergo mutations, and I'll explain later what the evolutionary significance of that is. But for clinical purposes, after radiation or chemotherapy, the pale, rapidly dividing spermatogonia are depleted. If there is any, and so there's nothing there except if there's any recovery of spermatogenesis, it could take several years. That sounds strange. How can it take several years? If we do chemo in a male for cancer, it may not come back for several years. He's azoospermic. And it's a shock. 4 years later, suddenly he's got normal spermatogenesis. Recovery is only from the slowly dividing dark spermatogonia pool, which contains spermatogenic stem cells. After discontinuation of testosterone, recovery is usually much quicker because the pale spermatogonia have not been depleted by the testosterone. So SSCs can produce spermatogenesis and restore fertility if transplanted into the rete testes. There should be no cancer cells in the testes of the prepubertal boy with leukemia after his initial remission, because the more sturdy SSCs will survive the initial chemotherapy and can be frozen before the more extensive later bone marrow transplant. They can then be thawed and injected into the rete testes of the patient after he is cured of the cancer, with no fear of transmission of leukemic cells back to the patient. This is an example. You can see it better in an adult, really. SSCs survive initial chemotherapy, even though the cancer cells do not. This is a 17-year-old with leukemia. And well, I guess I don't have, so okay, let me show you this is Tessa lab dissection. Now, if you want to preserve the SSCs, you don't do it like regular Tessa for IVF, because the SSCs are in the basement membrane. So the so-called tissue junk that you would throw away when you do the Tessa is what you got to preserve if you want to save the SSCs. So that's very important to know. What you normally throw away for clinical Tessa for IVF ICSI is what you absolutely want to keep if you're going to preserve the fertility with testis biopsy of a prepubertal boy. Now, this is what we do later, and I'll show you. We can, by ultrasound guidance, we can actually inject the SSCs into the rete testes. The rete testes is a linear collecting system, not like depicted in many textbooks of animals. In humans, it's a straight line in the center of the testes. And we can, under ultrasound guidance, slip this needle in there. And then when we make an injection in the rete, this is different than the mouse or the rat, you can see with ultrasound, keep watching, that we get colonization of all the seminiferous tubules. So all you have to do is inject spermatogenic stem cells into the rete testes in the human with ultrasound guidance, and you get colonization of all the seminiferous tubules with stem cells that will make sperm. So why freeze the ovary or testis after initial chemotherapy? Well, both the stem cells in the testis and the primordial follicles in the ovary are relatively resistant compared to the progenitor spermatogonia or developing ovarian follicles. The initial chemotherapy will eliminate cancer cells in the ovary cortex in the woman and in the testis tubules in the boy. Even though the female has become menopausal from her initial treatment and the male has become mesospermic, there will be surviving primordial follicles in the female and surviving SSCs worth cryopreserving in the prepubertal male. These are all the oocytes in the ovary cortex before chemotherapy in a female. And after chemotherapy, you can see destruction of a moderate section of the cortex with destruction of their primordial follicles. And in fact, after final chemotherapy, you see everything is gone. But if you froze the tissue at this stage, you will still have, after the initial chemotherapy, plenty of primordial follicles, but no cancer cells. And the same is true with the testes. So here's an example of the male similar to the female. This is a 17-year-old healthy boy backpacking in the west of America for a summer vacation. He returned to St. Louis for his senior year in high school in late August, and then became suddenly very sick, diagnosed as an urgent care center with the flu, but kept getting sicker and near death. Finally, he had a simple blood count and acute myelocytic leukemia was diagnosed, and he was near death. Given chemotherapy, and then he was in remission when we saw him, but azoospermic, due for the next round of serious heavy-duty chemo. So we did a testis biopsy. And this boy who was not prepubertal, but was in early puberty, is a very good example for us to understand how this works. It was a special example. So most of the tubules you'll see were Sertoli cell only. A few contain spermatocytes and spermatids, and many contain spermatogonia, pale and dark A, with obviously SSCs. But there were no leukemic, no malignant cells. Cryopreserved intact tissue pieces and testis suspension were done. And we also preserved scrotal skin. So we're going to answer why we want to not only preserve intact tissue pieces, but also a tissue suspension. So this is what it looks like initially after the chemotherapy. And if you look closely, it's Sertoli cell only, except you'll see spermatogonia are still present. And actually, in one segment, you can see that he didn't even destroy the mature spermatids. There they are. So he's going to have a slight recovery of spermatogenesis, but these mature spermatids, when they're gone, they're going to be gone. So his true recovery of spermatogenesis with normal sperm counts is going to be in 2 or 3 or 4 years from the dark type A spermatogonia, which contain SSCs. So for prepubertal boys with cancer and for young teenage boys, freeze the testis biopsy. But we should do 2 things. Half of it freeze dissected tissue, and the other half of it freeze little tiny pieces of intact testicular tissue. I'll explain to you why you should do both in the next section of this talk. Fertility can later be restored either by SSC injection into the rete testes or by autograft or even xenograft if there's a risk of cancer transmission. The SSC injection into the radius is obviously preferred if there's no cancer cells, but we also have the choice of being able to transplant little pieces of testicular tissue, either back to the patient or frankly xenografting onto any animal, a nude mouse really, and being able to get enough sperm from that tissue to be able to freeze and use for ICSI. So the rapidly dividing cancer cells will be destroyed by the initial chemotherapy, but the SSCs will usually survive. Now, I'll tell you a little bit about the work in the mouse and the rhesus by our colleague, Kyle Orwick, who's working in collaboration with us and Amanda Clark and Katsuhiko Hayashi on the whole project of in vitro gametogenesis and making sperm and eggs in the human from skin cells. So the strategy here was started by this author in 2004, showing that you could preserve reproductive potential in prepubertal boys undergoing cancer treatment. and you can render them fertile as adults because you can transplant primate testes. Well, this wasn't human, but primate testes by xenografting into mice. These were nude mice. So xenogenic sperm showed a fertilization rate after XE that was similar to that reported for rhesus testicular sperm. The resultant rhesus embryos also showed a normal rate of in vitro development, demonstrating that xenogenic rhesus sperm generated in host nude mice are fertilization competent. But then it went a long time, almost 10 years before Kyle's group was able to show that you can do autologous grafting of cryopreserved prepubertal rhesus testes into the adult rhesus and derive sperm and offspring from that. This is just a visual picture, and the pieces of tissue, these were not SSCs. The pieces of tissue were grafted onto the scrotal skin because the temperature would be cooler to give them a better chance than if they were transplanted onto the abdominal skin, a better chance of resulting in recovery of spermatogenesis. So during the 8 to 12-month observation period, grafts grew and produced testosterone. Amazing. And complete spermatogenesis was confirmed in all the grafts at the time of recovery. This is prepubertal rhesus testes tissue pieces transplanted back, frozen, and then transplanted back to the adult. Graft-derived sperm were competent to fertilize rhesus oocytes, leading to pre-implantation embryo development, pregnancy, and the birth of, actually, in this case, a healthy female baby. There are some pictures from the paper in 2019 that stirred everybody up. It was so exciting. And this is the baby rhesus resulting from prepubertal testes grafted to the adult rhesus. Now, this wasn't frozen prepubertal testes, so we got a ways to go on that. So fertilization competent sperm has been produced from fresh xenografts of prepubertal non-human primate testicular tissue transplanted into nude mice. And those results suggested that it may be possible to obtain fertilization competent sperm by xenografting small pieces of testicular tissue from a prepubertal cancer patient under the skin of mice, the scrotal skin. Xenografting would circumvent the risk of malignant contamination. If malignant contamination is not a concern, however, autologous testicular tissue grafting could be done so that it's put right into the adult if it was frozen. Now, as of yet, frozen grafts did not produce complete spermatogenesis, although fresh tissue did, but I'm sure this is a completely remedial problem. This is a generation of monkey offspring uses sperm derived from juvenile monkey testicular xenografts. So what do? Do we freeze just the cells or do we freeze the tissue? Well, we want to freeze both. We can easily maintain mouse SSCs in culture since 2003. And cultured rodent SSCs can be maintained in long-term culture with exponential expansion in numbers, and they can produce spermatogenesis and restore fertility when transplanted into the testes of infertile recipient mice. If there are no cancer cells in the testes after the initial remission, then the more sturdy SOCs, which survive initial chemotherapy, can be injected into the rete of the patient himself after he is cured of the cancer. Here again is that video that is very instructive. You can practice this really on your obstructive azoospermia patients if they give you permission before you do their surgery, and actually inject just ultrasonographic material into the rete testis to make sure you've got your technique well established before doing this with precious and valuable suspensions of spermatogonial stem cells. So we want to make sure we're right in the rete testes, and once we're sure, we inject, and it colonizes all of the seminiferous tubules. Look at that. So we can do that right now because we've perfected that technique, and we're just waiting for the IRB and the option to do that with patients that have had frozen SSCs. So let's go a little bit to Brian Herman's paper in which he shows that spermatogonial stem cell transplantation can be done into the rhesus monkey, even allogeneically, producing functional sperm. This is pretty amazing. It's because the seminiferous tubules are considered to be a immunologic privileged site. So autologous and allogeneic SSC injections were made into the testes of 18 adult and 5 prepubertal recipient macaque monkeys that were rendered infertile with alkylating chemotherapy. Autologous transplant, the donor phenotype was lentivirus marked SSCs, was evident in the ejaculated sperm of 9 out of 12 of these adults, and 3 out of 5 prepubertal recipients after they reached maturity. So allogeneic transplant, just like that, led to donor recipient chimerism in sperm from 2 out of 6 adult recipients. So 81 oocytes were fertilized, embryos ranging from 4-cell to blastocyst with donor paternal origin confirmed in 7 of the 81 embryos. So functional donor spermatogenesis can occur following SSC transplantation into primates without even using immunosuppression. And this is some pictures from Herman's paper that demonstrated this. Multiple mechanisms regulate immune privilege in the testes, including blood testis barrier that limits access of immune components to the differentiated germ cells via Sertoli cell tight junctions. That suppresses the rejection of immunologically disparate cells. Our data clearly indicated that cells from unrelated donor animals were tolerated in some immune suppressed non-human primates. Now, that is sort of my last slide, but I want to make a few points that I didn't prepare slides for in the last minute or so of this talk. So now we have actually performed successful allogeneic transplantation of ovary tissue from a sister who was normal to her sister that had Turner syndrome. And they were HLA good matches, but they were completely different individuals. It was not an auto transplant, and they weren't identical twins. And the immunosuppressive protocols that we now have that were developed in St. Louis and now are used extensively at Johns Hopkins, those immunosuppressive protocols are extremely safe. And it involves virtually no steroids after the first day, and only tacrolimus levels, which can be monitored for safety, and azathioprine, which is never really seriously toxic. And so we can plan on performing Sertoli cell suspensions from a brother, for example, to his brother with Sertoli cell only, with a rete testis injection. And maybe there won't be rejection in a lot of them, but there might be. And we can prevent rejection in all of them by using a safe immunosuppression protocol. And I didn't make a slide of this yet, I'm sorry, but the safe immunosuppression protocol involves a heavy IV dose of prednisolone, of course, the day of the surgery during transplantation, but also along with that, antithymocyte globulin. And that antithymocyte globulin really attacks the stem cells, and it really basically kills all the T cells in the bloodstream that recognize self from not self. And then out of the bone marrow will come naive T cells that are going to be rebooting the immune system, and that will recognize the graft as self. So you're just rebooting the immune system with minimally toxic immunosuppression. And we can do that for allogeneic transplants and transplanting spermatogenic stem cells from one brother and even from a cousin to a man with Sertoli cell only. So it's pretty exciting right now, the whole field of fertility preservation. And I mean, we were even able now to do IVM fantastically with and get 14 to 20 mature metaphase 2 oocytes from the ovary of a woman. We're doing an ovary freeze-on before we even freeze her ovary tissue. So we get as many M2 oocytes as we would from doing stimulation like for IVF. And indeed, we found that you really don't need stimulation for IVF, and you don't even need normal follicle function for meiotic competence. And the only reason we really form follicles is to get the egg out of the ovary. So for the male, it's very, very similar situation. And we're on the verge of fantastic breakthroughs And this new immunosuppression protocol that just reboots the immune system will make it possible for incredible allotransplants. So thank you very much for allowing me to give this talk. I love Quan Cho and my colleagues at Sun Yat-sen, Dr. Liu and Dr. Liang and Dr. Liu and all your colleagues. We really we love you and appreciate the privilege of being able to give this lecture. Thank you very much.